Good evening, everyone, and welcome to this MSF webinar on navigating the global pressures on humanitarian aid. My name is Simon Eccleshall. I'm the head of programs for Médecins Sans Frontières, or Doctors Without Borders, here in Sydney. And this evening, I'm going to be joined by two other guests to answer some challenging questions and to take your questions online. I'll introduce those colleagues in just a moment. Before we get started, I'd like to quickly acknowledge the traditional owners of the lands upon which I am residing tonight. They're the Gadigal people of the Eora Nation, and to send respects to leaders past and present of all Indigenous people across Australia or in New Zealand if you're joining us from New Zealand tonight. The agenda for this evening is in two parts. We'll have a 30-minute discussion about the changing humanitarian landscape and our panelists' responses to some questions on that. And then we'll open it up for an additional 20 minutes on questions that have been submitted by yourselves, the audience, for this webinar. I'd like to thank everybody in advance for submitting questions. There's been some excellent questions that have been proposed for our panelists this evening. We'll try and get through as many of them as possible in the time that allows. But before we get into the questions, I want to give a very quick introduction to our topic this evening, particularly the global pressures that are currently being faced by the humanitarian aid industry worldwide. I'm going to show just a couple of quick slides before we come to the questions. So the first slide is really emphasizing that perhaps more than ever, humanitarian needs are greater. Our world is increasingly fractured by war, by displacement, and by disaster. Yet at the same time, we're seeing that humanitarian action is being defunded, it's being criminalized, it's being attacked. At MSF, fortunately, we're not directly impacted by the massive funding cuts which have happened over the recent months because we don't rely on or accept government funding. But our projects, our patients, and their communities are massively impacted through the cuts to the activities of our local partners and of other NGOs that work alongside us in the field. Furthermore, the attacks on our core values, on humanitarian principles, the erosion of the protections that we need in order to be able to do our work, these attacks, these erosions are making our job just that so much harder, and it's further endangering our staff and indeed the lives of our patients. I'm going to show another slide now quickly on some of the drivers for change, and you'll see on this slide that we're dealing with not just funding cuts, but also more complex and protracted crises. Interestingly, 10 years ago, if we look at 2014, approximately 29% of the global humanitarian response budget was spent on protracted crises. If we look at the figure for 2024, this has now increased to 91% of the budget being spent on protracted crises. The climate crisis is really a change or a risk multiplier for our work. And the World Bank estimates are quite staggering. They're suggesting that in just 10 years, by 2035, there'll be an additional 100 to 144 million people displaced as a result of climate change. And now if we turn specifically to aid cuts, perhaps most publicized of these are the enormous cuts by the US government to the USAID program. In 2025, that program, with an annual budget of around 68 billion US dollars, that's been cut by 80% in 2025. And if we look at other countries, the UK, the United Kingdom has cut their official development assistance by 40%. France has cut their assistance by 37%. So we're seeing absolutely massive cuts to the humanitarian budgets that were already inadequate for meeting the needs that were appealed for through the UN and through NGOs on a year-by-year basis. I was reading today a report from Oxfam, which estimates that the USAID cuts will result in at least 23 million children losing access to education. and as many as 95 million people will lose their access to basic health care, potentially leading to an additional 3 million preventable deaths each year. And that's as a direct result of just the cuts to USAID. The final slide I'll show you for now is from yesterday's New York Times, and they've broken down what remains of the USAID budget, and you can see that very, very little remains in key areas where MSF is acting, particularly in mother and child health, sexual and gender-based violence, other areas that have been massively cut back as a result of the decisions taken by the US president. That's our preamble for tonight's discussion. These massive cuts are really what is overshadowing the need for change, adaptation, and rethinking how MSF can work in some of the world's most vulnerable and disaster-affected areas. I have the pleasure tonight of being joined by two colleagues. Dr. Tom Ellman is our director for the Southern Africa Medical Unit. Tom has been working with MSF since 1995 in Rwanda and now has over 25 years of experience in humanitarian medical work, mostly with MSF. His focus has been on HIV, TB, malaria in Africa and in Southeast Asia. Plus, he spent some time working on Chagas disease in Bolivia. Tom is joining us from Cape Town, South Africa this evening. Welcome, Tom. We're also very privileged to have with us this evening Louise Roland Gossen Mwamba. Louise is the current Humanitarian Affairs Coordinator for MSF's Operational Centre Amsterdam. Louise has worked in operational and advocacy roles in MSF countries of operation, notably in Democratic Republic of Congo, in South Sudan, and in Greece. And she's occupied a number of positions in headquarters as well. Between 2020 and 2022, Louise worked on the COVID-19 response, and Louise has worked with WHO in Somalia, as well as with International Planned Parenthood Federation. Louise is joining us from Nairobi in Kenya. Welcome, Louise. I'm going to turn now to our questions for this evening, and I'm going to start with you, Tom. Tom, at a medical project level in Africa and beyond, what are some of the changes that you are seeing to humanitarian aid, and how are the changes affecting our patients?
Thanks, Simon, and great to be here. So the impact's dramatic. It's hard to find the words, both the immediate impact and the fear and confusion that we're seeing amongst communities that we're working with. Maybe, I mean, it's a huge question. Let me perhaps just take some examples from Southern Africa, where we started 25 years ago when HIV was a death sentence, and the advances that have been made with the support of the international community have been incredible, such that it is now a chronic disease like any other, although there are still many, many people dying. In Southern Africa, particularly, the rollout has been incredible. And currently, globally, there are almost 20 million people reliant on USAID, US funding for HIV. The US provided over 70% of global international support for HIV and around 40% for TB. So those are two areas that we focus on. And just their support has particularly been important in filling in gaps. So the drug supply is one thing, but in order for people to take drugs, they need support, community groups, supply chains, monitoring, and the dependence and the disruption of those groups who have almost completely lost their supportive funding means that communities and patients are no longer able to get the support, and they're coming to our programs. We working, for example, in Harare, we work with adolescent girls, young women. We have an adolescent program. PEPFAR used to support the DREAMS program, which provided support, particularly in prevention of sexual violence, family planning, HIV support for over 10 million girls in the region. And that support disappeared overnight. The program collapsed after 10 years. So our program there is finding no other actors giving support, for example, for young women who've experienced sexual violence, and they're coming more and more to our program, such that we are flooded with demand. Similarly, all programs supporting populations, particularly high-risk populations, adolescent girls, and particularly sex workers, LGBT, in accessing prevention for HIV, they were also dependent on this funding, and the support disappeared. Access to PrEP to prevent HIV disappeared overnight. Another example, a more typical humanitarian setting in Cabo Delgado, one of the forgotten emergencies in northern Mozambique. We have practically lost the UN support that was providing security and support around some of the programs that we're working with. It's a very highly affected HIV and TB. Around 10% of the population have HIV. And when the conflict started, the supply of drugs to these people completely disappeared. So MSF stepped in to try to rebuild the program, but was still dependent. Although we are independent in our own funding, we still relied on drugs that were supplied through the Global Fund and PEPFAR. The supply chain collapsed. And while up till now we haven't seen massive disruptions of access to treatment, we have seen people being given fewer and fewer drugs, so they have to come back regularly in settings where they don't have the means to come to the facilities. So all those advances lead us to see a move back to where we were 10, 20 years ago, populations unable to access prevention for HIV, unable to access treatment for TB, and in huge fear about what's going to happen by the end of this year, when the funding really disappears, and at the same time, we see the Global Fund, the UN actors, other agencies disappearing from the environment.
Thanks, Tom. That's a very bleak picture. And perhaps, Louise, I could ask you the same question, but with perhaps a broader context. Tom mentioned some of those dependencies and the supply chains that MSF relies on. So what changes is MSF seeing to humanitarian aid, and how is MSF responding from your perspective?
Thank you, Simon. And I think you mentioned earlier on that MSF is not directly impacted by the funding cuts that are happening, because we take very few institutional funds. However, the whole ecosystem around us is heavily reliant on donor funds. And if we look at, we've been trying to track dependencies. So for example, some of our teams in DRC, in South Sudan, will take UNAS, so UN flights, to go to certain projects. These are falling apart in many of the contexts where we're working. They're no longer being funded. So we, in order to be able to do the same activities, will have to pay extra. We've been trying to estimate, right? But there is so many questions still in the air of how much funding that it's difficult to do that, but it's at least 20% more of funding just to do the same thing that we're doing in coming months, which is huge if you think of our budget. And this is at a time actually where there's going to be increasing, because little by little, a lot of the ecosystem around us is changing. So a lot of organizations are closing, activities are reducing. I was speaking to UNICEF yesterday in Nairobi, who was saying they have stocks of plum peanuts, or of food that is given to severely malnourished children. They have the stocks there, but they do not have any actors in the different countries in the region that are able to distribute it, because those funds have been cut already. So even though the food is there, it cannot be distributed. And in the next 6 months, as the year ends, so for the moment there is money until September, some money, even though part of it has already been cut. From October, it's the new financial year for USAID, it's the new financial year for many donors. This is where the bulk of the cuts. So there is this, Tom mentioned this fear of what is to come. And I think just to mention that it's been a few months of shock for the humanitarian sector and for the populations that we assist, not just because of the funding cuts, but also because of the rhetoric that goes around it, because of the acceleration and the accentuation of trends that have been ongoing for a while, but we're now seeing policies that are centering on national interest only. There's a defunding and deprioritization of solidarity, of helping people based on needs. And I think that's incredibly worrying. And then reframing humanitarian aid as a tool in a transaction, right? So I will give you money to fund your health system if you accept returns of migrants from third countries into your country. So it's incredibly transactional. And even if there was that transactional in these national interests before, it's really accentuated and it is normalized. And therefore, and you know, Tom again was saying there's these attacks on migrants and on migration, attack on reproductive health, attack on LGBTQI rights and gender. So I think it's this whole environment that we're worried about. But very concretely in MSF, what we're doing, we've put in place a dashboard for all MSF teams across the world. And we're trying to track very concretely what are we seeing in terms of changes. So changes to other actors operating around us, changes to donors in the environment in which we are at, changes potentially in Bangladesh. We just heard that there was a doubling of consultations in one of our clinics in Cox's Bazar, a number of our clinics, actually because all the other actors that were doing primary healthcare closed their clinics. So we're really monitoring this so that we can have a better idea of the direct financial impact if UNAS flights stop, if we no longer receive medication from the Global Fund or from different donors, but also so that we're able to pivot in terms of what do we change in our operations, and also so that we can do evidence-based advocacy. We want to be advocating, we want to be speaking out based on what we see. So we're putting a huge amount of effort on that.
Fascinating, Louise, and look, that I want to go a little bit deeper on that transactional nature or the conditionality that seems to be being applied to where aid is allocated and where not. Who are the cuts in aid affecting the most, particularly those US government funding cuts? Who do we expect to see the biggest impact of the cuts? Is it particular groups? Is it particular countries? What can you tell us that you're seeing about that?
So there's different ways in which you can see it, depending on the lens that you take, right? You can look at where were most of the funds coming. So the first thing is to say that obviously the cuts coming from the US are the greatest because the US provided 40% of humanitarian funds. But the UK, well, Germany actually is the second largest donor, then it's the UK, and those as well have reduced their funding. So it's in the accumulation of huge reductions from the key donors. And so certain countries are particularly impacted because they had such high reliance on US funding, on UK funding or Germany. So that can be South Sudan, that can be Bangladesh, Ethiopia, Afghanistan and Yemen are particularly impacted because actually cuts have been across the board, and it's 100% cut. There is no humanitarian funding from the US going there anymore. So certain countries are particularly impacted depending on what the national interest or absence of national interest might be, right? Countries like DRC might hope that because of their mineral wealth, they'll be able to get some funding in exchange for deals on minerals. Sudan, because of its oil wealth, might also be able to negotiate to have some funding for assistance. But across the board, I think what's important to say is I don't think any country will be spared by these cuts. Then if you look more at a population level, I think, and this is something that Tom has also alluded to, vulnerable populations and populations in humanitarian context are going to be the most impacted, unfortunately. And that is LGBTQI plus populations. That is women and children, and in particular women and adolescents. So there is an attack on gender, there is an attack on reproductive health and justice, so access to contraception, access to all sorts of services. And when we think, if at the moment we're trying to think of where will we prioritize, where are we most concerned about, vaccination is going to be significantly impacted very fast, because we've seen a reduction in community health workers already. Those are the first to fall. And therefore, these are the people that we would be engaging with communities, undertaking, for some of them, vaccination, malaria as well. So prevention activities around malaria have been significantly cut. And there's a huge mortality linked to malaria, and then nutrition, of course. And as I was saying, great reduction in food security programs, so programs that try and make sure that populations don't descend into malnutrition. So yeah, the concern is unfortunately across the board, with some countries or some population at more acute risk.
Yeah, thanks, Louise. I think I might take a segue from that part that you just finished on around communities and come back to you, Tom. Tom, beyond immediate medical relief, how are vulnerable communities across Africa, for example, how are they navigating this new crisis of reduced funding? And what can MSF do to strengthen their resilience as a community?
So vulnerable populations are used to being abandoned. That's partly why they're vulnerable. And we've seen, in fact, COVID showed incredible examples of how communities came together and developed resilience to these shocks of access. And we're seeing some of those things coming back. So as Louise said, communities, and particularly the most vulnerable communities, have been targeted, partly because it is part of the narrative behind some of the cuts, a deliberate targeting of certain groups, LGBT, sex workers, those requiring access to abortion care, for example. And those same groups were historically abandoned by their own governments. They were particularly dependent on foreign support, on US government, on EU support, and on organizations like ours to provide for their needs. The disappearance of that support has pulled the rug from under them. They were always resilient. They were always working, often in tension with their own governments. And now they've lost the last support that they've had. And I think that what we are seeing, so we work with sex workers, with LGBT, with adolescents. I was last month in Kinshasa, where the whole of Kinshasa, 20 million people, have been pretty much reliant on US funding for access to their HIV services. There's been a huge investment from the US, from PEPFAR specifically, a fantastic support to vulnerable communities, developing hubs at community level because they're criminalized by their own governments. They rely entirely on community networks. That funding disappeared. In one clinic, a brave Congolese doctor was providing specific services to over 2,000 gay men who have sex with men, who relied on, there's now an Mpox epidemic that you probably heard about going across West Africa. It's pretty much endemic now within the population, but sex workers, men who have sex with men, and HIV are particularly vulnerable to it. The support, this is now disappeared, and MSF is looking with these communities. So we're hoping that we will, our capacity is also limited, but particularly showing allyship and support to these communities and speaking up for them. Interestingly, these communities who were in tension with government, just about able to speak out occasionally, even though the legal environment has been becoming more and more risky with the death penalty for LGBT in a variety of African countries. Congo worsened its own legislation just last year. And they were able to speak out with support of the US. Now they couldn't speak out even about the loss of their cuts for fear that they would aggravate the funding environment. So many of the actors dependent on US funding would have liked to speak out and call for more, but they couldn't because of fear that they would be even more affected. So MSF's voice has been ever more important in supporting those voices and helping to rebuild their voices. So I'm hopeful that we will continue to provide, if nothing else, an opportunity for these communities to speak, give them some confidence. I think that the trust that MSF has developed with vulnerable communities in many settings is critical to rebuilding their capacity, and in some settings, working with them. But I think one of the important issues for the future in MSF, and I think across the organization, an increasing recognition that we are highly dependent on communities to ensure that our activities work. So this idea of independence from government comes along with dependence, mutual dependence and support with communities. And it's perhaps one of the silver linings that we will, as an organization, become ever better at developing support for our programs and for their communities through developing networks more strongly.
Yes, Tom, that's a theme I want to continue with you, if I can, with this next question around dependencies and how MSF is working as part of that bigger ecosystem with communities. Tom, one of the earliest and most dramatic cuts that we saw to USAID that was announced by President Trump was to cut funding from the World Health Organization and to cut funding from medical research. Can you explain how, if and how, this will affect MSF's work and the implications of cutting research for MSF's patients?
Yeah, it doesn't even require enlightened self-interest to realize what a huge self-inflicted wound this is for the world, removing support to research, which has underpinned all of the advances that we've made across health in the last 25, 30 years. And they have been incredible advances in the sphere of HIV, as I said, going from no one on treatment to HIV being not only a treatable condition, but now we, just in the last few years, have seen the arrival of long-acting injectable treatments, which potentially with one injection a year can prevent HIV, almost a vaccine, almost 100% effective. So these advances have come with research, and there is every hope that in the next 10, 20 years, we will come up with vaccines to prevent HIV, to prevent TB, to prevent malaria. Much of that research has been dependent on partners in Southern Africa, and South Africa has been particularly affected. South Africa's been behind most of the advances in research on HIV and TB in the last 20 years. And particularly, you probably will have heard this crazy rumors that were circulated about white people being attacked in South Africa, and that is seen as behind a particular targeting of South Africa for removal of not just support to its HIV program, but support to the research upon which the world relied, and MSF. So what was also particularly valuable about the research done in this region that MSF's often participated in has been a focus on research for equity, research for poor communities, as opposed to research that would only be accessible to the wealthy. So making tools, diagnostics that can be managed by adolescents, by young people, by communities, illiterate communities at home, treatments that can be taken without needing to come back regularly to see a doctor, models of distribution that allow people to take 6 months of medicines and come back only once a year to see their clinicians. So the depth and breadth of loss that is implied by the removal of research funding is unimaginable. And alongside the removal of direct support for medical support, for humanitarian support, we are handicapping our future unimaginably through reducing that research funding. And WHO as a key player and a key trusted player in ensuring, perhaps it's a theme we could come back to, the role of science and the attack on science that lies behind this, that we saw during COVID, all of the rumors and fake news that was put about by politicians around what this disease was. Exactly that same principle underpins and threatens the future of research in medicine. And I think MSF, in addition to being a humanitarian player, is a key scientific player. Data and science underpins what we do.
Thank you, Tom. That's indeed a very bleak picture, and a feeling that these cuts set us back, not just in the short term, but without that funding being restored to something as critical as research, they can set us back decades or generations, which is heartbreaking in this context. Louise, I'm going to come to you with a question beyond the funding cuts. So we've also seen states moving away from, or at least failing to defend, the established norms, the established principles that provide protections to healthcare facilities and to personnel during conflicts. These norms and principles are often captured in something described as international humanitarian law. The attacks that we've seen in the last 18 months or more now on health facilities in Gaza, in Sudan and in Ukraine, unfortunately seem to be becoming the new normal rather than being strongly condemned by states and immediately investigators and the perpetrators brought to justice. We're seeing impunity. We're seeing a lack of action. How do you react to this? What does this mean for MSF from your perspective? And what possibly could MSF do to pressure governments to act more responsibly? I know it's a huge question. Grateful for whatever reflections you can bring to this important and sad change that we're experiencing.
I think this comes back to, Simon, what we said earlier about the fact that what we're facing at the moment is an acceleration and a worsening of trends, and not only around funding, but a lot of other aspects, and the erosion of international legal norms. And I would put humanitarian law, and that's the laws of war, but also international human rights, because I think both are important, and because both impact the environments in which we work and the populations that we seek to support. So indeed, last year, if I'm not wrong, was the deadliest for humanitarian workers. And MSF is not spared. In Gaza, we have lost so many colleagues. Same thing similarly in Sudan, in Myanmar, in many different contexts. And I think what we try and do, so what's really complex is that before these norms were still accepted, before we could still hold parties accountable, there was still an element of them trying to explain why they deviated from this norm. I think what's really worrying at the moment, and I studied international humanitarian law and human rights law actually, is that there is no longer any attempt to really say that you value following these laws. So for us, what's important is the protection of the medical mission, protection of health structures, health personnel, humanitarian personnel and infrastructure, but also protection of populations against widespread violence. And we have seen, entire refugee camps, populations being targeted in Sudan in many different contexts. So what we really are worried about is this impunity, absence of accountability for these attacks. We certainly document and speak out about these attacks, and then there is a judicial process further down the line that may take this public evidence that we share. We organize big campaigns like we have at the moment in the Netherlands and in the UK and other countries that we've contributed to really insist on the protection of health structures, protection of civilians. And we try and push back with governments. So we engage directly with, obviously, with Israel, with the Israeli governments, with Hamas, with different armed groups. Myanmar as well. I mean, we often talk about Gaza because it's very stark examples. We often talk about Sudan or Ukraine, but it's also happening in South Sudan. We had a facility bombed just weeks ago in Myanmar. So many of our health facilities have also been targeted. They are not just bombed accidentally, they are targeted. And this is what is so shocking, is that aid is used as a tool to displace population, and we see this very acutely in Gaza. It is used to starve population or to pressure armed groups, and we see this in Sudan with the government forces or RSF forces denying access to humanitarian assistance in territories that they control. And essentially the instrumentalization of this aid as part of the political and military tactics. So we do our best, we engage with these groups, we engage with governments. But I think what is important is as well for us to engage with supporters, to engage with communities, for them to also make the case for the importance of these normative frameworks that help protect population.
Thanks, Louise. You mentioned a lot of things there, which we will touch on again, I think, in reaction to some of the questions that we're receiving online. I want to pause now. That's the end of the first part of our webinar this evening, with the questions curated from me about the changing landscape. What we're going to do over the next 20 minutes or so now is move to the questions that we've been receiving from our supporters and the audience who's online with us this evening. So there's a number of questions there that I'll probably post to both of you to get your different perspectives on. Time permitting, we'll get through as many of the online questions as we can. I'm going to start, Tom and Louise. The first question that we've received from our supporters this evening is a tricky one. How does MSF make decisions about how to allocate resources, particularly when there are increasing conflicts and disaster situations across the globe? Are these resource models changing in response to the US government's decision to withdraw foreign aid? Louise, do you want to kick us off? How do we make decisions about where to allocate our scarce resources?
We're kind of struggling at the moment, aren't we, Simon? Just trying to understand how dramatic the changes are going to be to funding and to our ways of working. We produce analysis, we try and work on modeling. We, at the moment, to be honest, are trying to identify within MSF what are the what indicators we are going to use to drive our decision making. We are not able to say at this point, this is, we are going to close operations in these countries, we're going to open in these countries, we're going to shift to first line HIV treatment everywhere. We are going to, because there are too many unknowns for the moment. But I think what we are doing at the moment is trying to prepare the different scenarios and what we might do. The first thing is we really base our activities and our responses to what the greatest needs are. And so indeed, this will kind of depend as well on which countries are more acutely impacted, or which areas are more impacted. If it's sexual reproductive health, for example, if it's first-line HIV treatment, and Tom can speak more to that. But we're certainly realizing that a lot of the assumptions that we had based our previous operational prioritization on are no longer valid. We no longer have, some of the big donors that are going to be funding HIV drugs or TB drugs or malaria, mosquito nets, or we no longer have the workforce that there has been working on vaccination. So we have different MSF sections, and to some extent, different MSF sections have different strengths. And Tom works for MSF is affiliated with MSF Belgium, and they have, some particular expertise on HIV, on TB, which other sections, possibly have a bit less of. In OCA, we have worked extensively on neglected tropical diseases and other elements. We are getting ready to scale up, for example, our sexual reproductive health work. So taking up a lot more of that work, because we know that it's going to be defunded. We're also going to be basing our decision-making on where we're going to manage to get access, because access is getting harder, whether that is in Gaza, in Myanmar, in lots of other countries. And we will have to change the engagements and the negotiations that we do to improve that access. We have to make sure that we are speaking to Turkish diplomats. We need to make sure that we are speaking to actors in the Middle East. We need to make sure that we are really stepping up our negotiation tactics. And then we will also have to make choices, and these are always very difficult ones, that Tom is also maybe best placed as a doctor to talk about choices that you have to make based on where, the greatest mortality is, where you might have better chances at preventing rather than just treating.
Thanks, Louise. I think we will segue to Tom now with the same question. Tom, how does MSF make decisions about where to allocate resources, and how might that change? Are we going to be able to scale up? Do we fill gaps? Is access changing? What are you seeing, and how do you think the model will evolve?
Well, the first thing to say is that we've always had to make impossible choices. We have always had to make decisions around opening one program at the expense of another, closing a program, and I'm sorry to say, abandoning populations. We have had to do it. We will continue to have to do it. I think that the question around how the current retreat throws into sharp relief the deficiencies in our systems and how we make those decisions. And I think that it's really important as an organization, and that we're putting a lot of attention into this, in being more explicit with ourselves about how we make very, very difficult choices that inevitably involve crossing red lines of quality, of access, of need with populations. I think it's also really important to remember that we do two things. We provide services and we speak out. Our ability to provide services is not going to dramatically increase. In fact, there is real concern that we may not, there will be increased competition between NGOs for scarce resources. We are incredibly reliant on our donors and on the allegiance, the relationship that we have with the donors to MSF. But there are going to be threats. So that second element of our speaking out becomes even more important, and how we invest both in speaking out against the cuts, speaking out in support of other actors, other donors, other governments stepping in, and a reversal of the catastrophic line that the US and the EU and many other donors are currently taking. That is also a critical part of our activities, and it requires investment. In terms of the specifics of how we would make choices, it's always going to be made on a balance. Of course, the need of the population, the absolute desperation and needs are a fundamental part of our decision making. But those needs are so great, as we've always said, we could pour all of MSF's resources just into one country, Democratic Republic of Congo, and we would not meet the needs. So we also have to consider the impact, not going as far as full cost efficacy studies that many governments would do in order to work out where best to place their resources, but on that delicate balance of the potential to meet the needs and to show solidarity with abandoned populations and speak out for them, the potential impact of our activities. We want to make a difference. We don't want to just be throwing our support into a bottomless pit of need without any evidence that we're bringing about change. And we want to transform. And I think that role of MSF in transformation is ever more important. And, a lot of these discussions are really depressing and bring us down. The possibility of change is what we live for as an organization. And our ability to make those smart investments, retaining diversity in an environment that might tend to push us towards only the most difficult, the most desperate conflicts, is something that we are resisting. We need to maintain the diversity of our organization, because you actually never know where the greatest global impact, that transformative potential, is going to come from. So I very much hope that we're going to do better on it. But I think as an organization, we have a very mature approach to balancing those almost unbalanceable decisions.
Thanks, Tom. You make, as you say, impossible decisions sound positively rational, but we can't take away the emotionality of that in this current crisis, where we have ever-increasing humanitarian needs and a shrinking pot of humanitarian funding. And that's going to be the trend that we grapple with for the coming years. Louise, another question from our audience tonight, and we've touched on it a couple of times already in your answers. Is it becoming more dangerous for MSF to work in conflict-affected areas? And how do you care for local staff when their access to food, their access to water and shelter is threatened?
Indeed, and I think I already mentioned that quickly. It's a very, I started with MSF, I think, in 2010 in South Sudan, or 2009. And it's certainly quite depressing to see the number of colleagues that I have worked with who have lost their lives in South Sudan and in other contexts. And I think that that's a very tough reality. Now, ensuring that the safety and security of our staff is a day-to-day work, and it's made more difficult, as we mentioned before, with the erosion of international humanitarian law but it is, I always have amazing memories. For example, in DRC and Misisi project, we had an amazing project coordinator, Sophie, who would spend her whole day on motorbikes in the mountains of Misisi, and most of her work was actually going to meet the different armed groups and negotiating with them, making sure that they understand what MSF does, that MSF will treat the families of these commanders, the families of all people. And that's, the day-to-day work that we do to negotiate access, to make sure that there is acceptance, to make sure we also do significant deconfliction. So we engage with armed actors and make sure that they know the location of our health structures so that they bomb them. Health centers used to be a protected space, and so staff and families would seek shelter there. This is eroded in Gaza, actually, with health centers becoming targets of attacks, and that's been really difficult. We have safeguarding teams, and we have teams that we put in place in particular contexts, like in Gaza, in Sudan, when there's been big spikes in the conflict, in Myanmar, and their role is to support staff. So make sure that staff that are able to leave the country, whether they are international staff or locally recruited staff, are able to leave the country, making sure that they have advance payments to be able to travel across the country and meet their needs. So we have specialized teams and multidisciplinary teams that will work on that, but that remains a very difficult reality, that our locally recruited staff are particularly impacted by this growing insecurity and attack on health workers.
Thanks, Louise. Tom, have you got anything to add on this? What are you seeing around this erosion of protections, particularly the impacts of that for MSF's local staff?
Yeah, MSF has always relied on the trust and respect of the communities, of the armed groups, of the governments. It is the only way we can work is through trust and respect. We will never maintain our safety in the way that the so-called Gaza Humanitarian Foundation are providing aid in Gaza. This idea that you can protect your aid through fear, through developing relationships where communities respect you only because of the fear that you bring to them, is a non-starter. So MSF and how we maintain the trust and respect of those that we work with is going to be absolutely fundamental. It always has been, always will be. There's no question that the erosion of humanitarian law, the diktats of various governments around the world undermining our action, and the potential that they have to amplify those voices through control of social media and the media in general is probably one of the greatest threats we face. And I think that we need to look to the communities that we work with in the countries ever more. That partnership that I talked of earlier is part of our protection. It's part of our safety. And if we lose it, we lose ourselves as a meaningful organization. Similarly, our relationship with our donors. Over 7 million people internationally trust MSF to provide the care that we do. And we need more. We need not just the money, we need the voices. We need those people who, because I think that as we speak out, and we must continue to speak out against what is happening globally, we face threats of recrimination. While we are independent financially, there is every possibility, and we have already seen fake news outlets spreading rumors, gossip, fear-mongering about what MSF does, suggesting that we ally with terrorist groups, that we support illegal activities, that we are a political organization. That is going to increase. And we will be ever more reliant on people whose trust we need both to provide our services and to exist. So I'm hopeful, despite all that's going on. I truly believe that the model that we have developed over the last 50 years, one that relies on communities and on independence, is one that will serve us ever more strongly in future. And I hope that it will infuse humanitarianism with more and more recognition of the importance of that trust.
Thanks, Tom. That's a really important point around one of the additional challenges that humanitarian aid work is facing, and that is from technology. And as you mentioned, social media, the prevalence of misinformation and disinformation is now at such a level that it's impossible for organizations like MSF to be able to correct every item of misinformation. But what is important is that we put out a reliable, trustworthy counter-narrative, that's rooted in the evidence that we see in our projects, that comes from the voices of our patients and our staff, and that people are more discerning around the sources of information when they want to get to know what the real situation is on the ground. They turn to organizations like MSF for an objective, impartial humanitarian view. And that, as you say, it's a struggle that we will have to rise up to in the coming years. Tom and Louise, we've got a number of questions online tonight, specifically about the situation in Gaza, particularly about how Palestinians' access to humanitarian aid is challenged. And I'm going to link it to another question that I saw online, which is, how is MSF able to bring political pressure on governments to act in a humanitarian manner? And this caller's referenced Netanyahu and Israel, but equally it could be applied to a number of contexts. How does MSF speak out, as you were saying, Tom, in bringing political pressure on governments to act in a more humanitarian manner? Louise, do you have an answer for that?
Very quick thoughts, and maybe hand over to Tom if you want to add. But I think Gaza has been a context and a war and a genocide where it has been near impossible to ensure that there is respect for humanitarian principles, for the ability of aid organizations that provide it, because it fundamentally goes against what the objective of the Israeli state is, which is to displace the population and So that has been a real challenge. What we obviously have direct engagements with the Israeli authorities, with COGATs, also with states that might be able to influence the Israeli authorities, and we're trying to make sure that we increase the political costs for allies of Israel to no longer provide the arms that are killing and maiming the children that we treat in our facilities, that are starving the populations that we're trying to access. So it's a really difficult one, and we really try and see the influence and the leverage that we have, if it's not with the warring parties themselves, if it's with the other governments or actors that may be able to have greater leverage than we do.
Indeed. And Tom, if you'll allow me, I might just answer quickly from the MSF Australia perspective on this one, because advocacy, speaking out, or what we talk about in French as témoignage, is a key part of what we do in Australia in trying to influence policymakers, decision makers around how they allocate resources and where they bring their pressure to bear. There is a regular, steady dialogue that MSF Australia has with the Australian government about the situation specifically in Gaza. We've been very vocal from the beginning of the current crisis in calling for a ceasefire, in calling for humanitarian access, in calling for respect of the decisions of the international courts and respect for international humanitarian law. But we recognize that those calls have largely gone unheeded. And so we, together with other humanitarian actors in Australia, strategize and work out ways of influencing politicians, influencers of those politicians in Australia, unions, communities, branches of political parties, how we can influence those to be able to influence the policymakers. Right now, MSF Australia is engaged in monthly briefings of new MPs. We have a large number of new MPs and new advisors, and they are very keen to hear about the situation on the ground firsthand from MSF workers who've been recently working in Gaza and in the West Bank. And so when our field personnel return from mission into Australia, we often bring them with us to meetings with MPs so they can share their firsthand experiences of what life is like for Palestinians, what it means to be deprived of food and shelter and water, and to endanger your life to go to an aid distribution point to try and receive food to feed your children. So those stories are regularly shared with decision makers in Australia. And we've been encouraging Australia to act as a middle power with other states. Some of the states we mentioned today, Louise, Germany, Canada, Australia and New Zealand in our part of the world, have not been afraid to speak up and to try and create a middle power voice, a voice that is in some regards still in close friendship with major powers like the US, but is discerningly different in the message that we're putting out on what is acceptable and what action needs to take place. For MSF Australia supporters, for you online this evening, there is a slide that will appear on the screen in a moment about a petition that MSF Australia has been running for the last few weeks since the federal election. And that petition is going to be tabled in Parliament at the end of July, coinciding with the first sitting week of this new government in Australia. And it calls for three things. It calls for protection of lives in Gaza. It demands that the siege of Gaza be lifted. And it also demands a point that Louise was making earlier, and Tom, that aid has become weaponized in many contexts, and we're demanding that the Australian government do everything in its power to stop the weaponization of aid. And indeed, the government of Australia has limited power in a context like Gaza, but it has the possibility to use all diplomatic channels available to it to put pressure on the Israeli government. So that's what we're calling for in that petition. We are, Louise and Tom, just about out of time. I think we've got about 30 seconds left. I'll quickly come back to you both, especially with a vote of thanks for spending your time with us this evening, for providing your very candid, very open, honest responses to some really challenging questions. And I want to thank also all of our people online tonight. We can't do this alone. We rely on our supporters to be able to provide the support for MSF to work around the world. And at the end of the year, it's the end of the tax year in Australia, we're asking for all MSF supporters to think about providing a gift to support, a donation to support MSF's work in these very challenging times. There's some QR codes that'll appear on the screen now, and we'd like to thank you all again for the amazing support that you give to us. Thank you, Tom. Thank you, Louise, and a good night to you all.
Thank you, everyone.